Okay, thank you, Chair. And I'm very happy to attend. This is my third time to attend this meeting, so I'm very happy to be back. And today I want to share some of our experience. Actually, most are animal studies, so it's limited in this area. And I have no contrast of infant care, maybe a little bit because I'm good friend of many authors in the paper. I will try to introduce to you. And for resuscitation, and we may know that actually we are trying to aim many goals. So maybe we have to instill to the goal of the why we are do resuscitation. And the next step, we could try to introduce the microcirculatory dysfunction to you, and then how to investigate the microcirculation. And finally, we go back to what if we do full resuscitation, what is the impact on the microcirculation. And the next is the problem of the screen. Actually is a fog. So if maybe you have seen this paper, that's a very interesting paper. It's written by a free optimization group, and it was conducted by the Michael Pinsky. And there are 72 research, they try to have a consensus. So I will recommend this paper to the young doctor to see. And in this paper, they try to introduce most we can do to resuscitate the shock is to use fluid or to use drug. And you can increase the balance, you can improve the lung function, and also you can try to manage the tone of the vessel. And then the goal is to target the organ, to target the mitochondria to have good function. And also you want to have the adequate function of every organ. But unfortunately, the fluid, if you give too much fluid or you didn't use the drug carefully or wisely, you usually cause many harm by using this fluid or drug. So sometimes at the same time, we may cause harm. And sometimes if you're not wisely to use it, actually will cause more harm. So what's the goal of our resuscitation? I think maybe the most doctor will say, yeah, we try to have a good blood pressure, so you can aim at a target MAP. And maybe you can use fluid, maybe you can try to measure the fluid responsiveness. And then you will maybe able to use best pressure. So actually the question is very difficult. You have to step by step, and you want to have the good oxygenation, so you have to consider more and more. So actually we have to go back. Yes, our final goal is the tissue perfusion and remove toxin. So actually that's more like a strategy. That's more like an intervention you do. So we always have to go back. What's our final goal of a resuscitation? So yeah, maybe the oxygen saturation maybe 1 gauge because you don't have any other better way to measure. Sometime later, maybe close to the tissue perfusion. I just say close. Now, meaning so urine output might be, and injury marker might be. And so what's the microcirculation stand here? So many may not be able to notice that what is microcirculation is doing. And sometimes you may have heard about the DIC. So sometimes there's many micro thrombosis. So actually this is the gray area. Maybe some doctor didn't notice that. And now we have more to do rescue, because if you fail to use fluid or you fail to use drug to resuscitate your patient, sometimes maybe we think about the endotoxin removal and cytokine removal, toxin removal, and steroids, vitamin C, thiamine, and many things you can do after that. So actually for shock resuscitation, it is very complicated situation. You always have to think about next step, if everything is okay, and my final goal is matched. If I fail, if I have any rescues. So it's a very difficult problem, but do not worry, you just try to focus back to the microcirculation. So actually it's about almost 14 years ago, there's a paper, actually I think by many good friends, they have published this in Critical Care. They try to mention that, as you can see, the microcirculation have some key effect factors, like endothelium maybe get injury, your red blow up cell maybe lose the ability to deform it, and your leukocyte maybe have inflammation, and your smooth muscle may be dilated by the NO, or you get a severe problem of the coagulation. So actually 14 years ago, they already recognized there's a microcirculation dysfunction in a sepsis patient, and we'll introduce that later. So at that time, they caused a syndrome called as a mitochondrial and microcirculation and mitochondrial distress syndrome. But unfortunately, because it's very difficult to test the microcirculation, it's very difficult to test the function of mitochondria. So about this concept was talked about 14 years ago, but we still have limited knowledge about this syndrome. And the next step is that we try to have the concept of microcirculation. The first step, it looks like not bad blood pressure. It's not okay. But I think it's if your patient have high dose vasopressor, then you have to be worried about the patient may have decreased more vessel density. So that's not a good situation. So even the two patients have the same blood pressure, you should be careful. And another situation is that it looks not bad because it's even higher than the normal value. But if your patient have the problem with coagulation, some blood vessel might be obstructed by the thrombus. So at this moment, you can see maybe some area they cannot have blood flow, so they do not extract the oxygen. So that will have a false positive, higher oxygen saturation. So this is a problem we have to be careful. And the next step is normally the vital organ have fewer vessels, but the non-vital organ has more vessels. But the vital organs, the vessel will well perfused. During the sepsis, the NO or other toxin will cause the dilatation of every muscle. So that's the first step. While in the septic shock, we have to give a lot of fluid because every vessel is trying to dilate. And the worst of after that is if your glycocalis was destroyed by endotoxin or inflammation, and you have the capillary leakage. So how to investigate the microcirculation? I think maybe it's about almost 10 to 12 years ago. This is the second generation of the microvascular video scope, and it can, because the LED green light can be absorbed by the hemoglobin, so you can easily to see the red blood cell to flow through the vessel. So I think that's very clear. And then it's the third generation of the microvascular video scope, and it looks lighter and looks easier to operate. But it still needs training to get a very good quality of image. So these two professors are my good friends, so it's maybe my only conference of interest. So they have teach us how to evaluate microcirculation about 12 years ago. They say normally you will say small vessel, it means the vessel, the diameter less than 20 micrometers. But actually I found sometimes they do study, they will publish maybe a diameter less than 25. So maybe I guess if you are facing a different situation, maybe you have to choose the different definition. So that's we have to be careful. Normally in this consensus is vessel diameter less than 20 microliter. So it was easy to get a total small vessel density. By today's knowledge, it can be automated, analyzed by the software. But for the perfused small vessel density is the limitation today because it needs the research nurse to define the flow of each vessel. So that's semi-automated. So that's the most fluctuation step when you are doing a microcirculation research. So if you have perfused small vessel density and total vessel density, you can just divide it, and you can have a proportion of the perfused small vessel and you have a definition of blood flow classification, and it looks like this, make it simple. And you can also have the microvascular flow index. It's very easy at the beginning, but it still be semi-automated. So you will choose the divided image to 4 quarters, and then you will define each area, the blood flow classification, and adjust the mean of the 4 quarters. And HI normally is as low is good, is high is bad. Okay, so let's see the Daniel Baker and John Vincent. They do a very simple study 17 years ago, and it just tell us if the patient with the lower perfused small vessel density will have lower chance to survive. As you can see, actually they only use 50% to prove what they see. And this is the paper from our study. Yeah, we have the same observation and same result after maybe 16 years ago. It still exists. As you can see, the lung survival actually have very low. If we can compare to the PSVD is 15, and compared to the normal health patient is 24. So that's quite different. Almost only 2/3 of the perfused vessel density. And you also can use it to predict if your patient have a very low proportion of perfused vessel. As you can see, the ROC curve was much better than the other MAP or SpO2 or even LACTAT. And as you can see, if you have a very low perfused vessel density proportion, and you will have very high mortality. If your PPV is good, and your mortality will be low. And how about early microcirculation perfusion? If you can improve the microcirculation very early, it means maybe 6 hours or not less than 24 hours, and maybe you can decrease the severity of the multi-organ dysfunction. So it means that if you can increase the microcirculation early, and you are able. So if your resuscitation didn't improve the microcirculation, and actually you can see the multi-organ dysfunction severity will increase, and the patient will become worse. So the next step is that can we select a patient to eligible for free therapy? And in this figure, as you can see, there is no microflow index group, and there's high microflow index group. As you can see, for the high, they're already good, so actually you giving fruit, there's no effect. But for the low MFI group, if you give fruit, you can improve the microcirculation and also the patient's outcome. So you have to be careful. So you will have to look more. If the high MFI group, maybe you give free, may not get any benefit. So how about the effect on free microcirculation? Now we look at different type. So as this study you can see they try to use crystalloid and colloid. Actually, in many animal studies, colloid can have better microcirculation, but actually the condition is very complicated in clinical trial. So unfortunately, in this trial, they didn't see the difference between the crystalloid and colloid, but they find if the patient was early, in the early group, just give free, it can improve in microcirculation. And the second is similar to the previous result we report. If your patient have a PPV lower, and the patient will have higher chance to improve microcirculation after you give them free. So now the issue about the microcirculation is the hemoglobin level, because now we have many consensus about when to target and when do you start to use to transfusion. So as you can see, if your patient have a baseline lower or bad microcirculation, when you give blood flow, and it can improve the microcirculation. So actually, because you need a hemoglobin, you need it to carry the oxygen. So yeah, if your patient have very bad microcirculation, when you give a transfusion and his anemia, it will help. And how about the storage of the RBC? It seems that a little bit slightly will be influenced if you put your red blood cell longer than maybe 30 days or 40 days. As you can see, there is a slight change because they think if you reserve the pack RBC longer, it will lose its deformity ability to deform. So that's a problem because if the red blood cell can be deformed, and he might obstruct the micro vessel because as you can see, actually the RBC is larger than some small micro vessel. So it needs to be deformed or even be packed or folded to pass through the vessel. So the next step is that maybe when next time we try to give blood to the patient, we have to consider in the microcirculation aspect. Try to maximize the benefit from blood transfusion and minimize the risk. Another issue is that it's almost 11 years ago, but I think it's still a very important issue because normally we will say maybe we just stop to give blood transfusion when the hemoglobin level is less than 7 or 9 or 10 or 12, depending on different situation. But actually for different organ, the toleration of the hemoglobin level is different. So in this study, as you can see, the part A is the heart. Heart is very well tolerated to low hemoglobin level. So even if the HCT is higher than 10, the heart is easy to extract oxygenation. The second one is kidney, the C. We start from C. C is for intestine. As you can see, intestine maybe the HCT is higher than 20%. The intestine can easy to get oxygen. So the last one is the kidney. As you can see, actually the kidney near higher hemoglobin level to extract enough oxygenation. So normal patient is okay, but if your patient are in shock or in danger, or especially in anemia level status, we have to be very careful. Different organ maybe depend on different hemoglobin level. So at the end, next time we thinking about the shock, thinking about fluid resuscitation, maybe we may try to consider both. Unfortunately, the microcirculation investigation is limited to clinical practice, but I think maybe in 3 to 5 years, maybe we can have new device, we can have new software, and because the computer now is get advanced and advanced, we are easy to have more powerful computer to do that. So maybe in the future we have to consider this both situation at the same time. So if we drive a car in the fog, we have to try to turn on the fog light. So like you have go direct monitoring, maybe both for the microcirculation or also microcirculation, and then we can try to do a better go direct therapy. So maybe in the next 5 to 10 years, we have to try to optimize both microcirculation and microcirculation. Thank you.